Great. She's ready as ever.
Thank you, Dale.
Good afternoon, Dr. Freer. Would you like to get started?
Yes.
Right, give me 1 second here. All right. Good afternoon, everyone. Thank you so much for joining the Los Angeles County Department of Public Health for a media briefing. Today is Thursday, April 28th. We have Dr. Freer presenting. Once Dr. Freer is finished, we will be doing a question and answer period. As a reminder, if you have a question, please use the hand icon or you may chat me, the host. Dr. Freer, when you're ready.
Thank you, and good afternoon, everyone. Thanks for joining today's briefing. I'll open, as always, with the status update. I'll review current metrics for our early alert signals and preparedness measures, talk a little bit about vaccinations, and close with some reminders about masking. And then, as always, happy to answer any questions. I'll take the first slide. Over the past week, the number of cases has continued to increase. And today we're reporting 2,335 new cases. The average number of daily new cases reported over the last 7 days increased to 1,764. This compares to an average that we reported last Thursday of 1,261. So a 40% increase in just this last week. Our 7-day average daily case rate, of course, also increased, and it's now at 17 new cases per 100,000 residents. I think last Thursday we were at 12 cases per 100,000 residents. The weekly case rate is now 126 new cases per 100,000 residents, and that means LA County is again experiencing a high rate of transmission. The average daily test positivity rate remains relatively stable. It's at about 1.8%. Unfortunately, this week, hospitalizations, as you could see here, began to slowly rise, small increases each day in the number of people that are hospitalized. Today, there's 249 COVID patients currently hospitalized in the county. Again, relatively low numbers, although we have seen a steady increase. With deaths usually a lagging indicator, we do continue to see, and we're grateful for this, relatively low numbers of daily deaths, with an average of 7 daily deaths reported over the past week. I do know that every person who's died due to COVID-19 is leaving behind family members and other people who love them, who are grieving their loss. And I do want to send my deepest sympathies, my hopes for strength and comfort to everyone who's lost someone from COVID. Next slide. As always, it's helpful to review our metrics over time. And on this slide, you can see the trends over the past 4 weeks for our 7-day average daily cases by report date, the 7-day average daily hospitalizations by admission date, and the 7-day average daily deaths by report date. While our 7-day average daily cases shown on the green line are far lower than they were during the winter surge, they've been steadily increasing since the end of March. For the 7-day period ending today, this average of over 1,700 cases were reported each day. And as you could see, the line got slightly steeper. The 7-day average of daily cases that we're reporting today is really, I think it's almost 3 times the average that we saw a month ago on March 28th. While the 7-day average hospitalization rate shown in that orange line has been slightly increasing recently, it's remained relatively low over the past month. Stable hospitalization rates reflect likely the customary lag we see between cases and hospitalizations, as well as the protective effects of vaccinations, boosters, therapeutics, and the natural immunity that some people gained when they became infected with the Omicron virus. As noted earlier, the 7-day average of daily reported deaths shown by the blue line continues to really decline slightly. at about 7 daily deaths now. It's a third of the average from 1 month ago. Next slide. The community level rating, the CDC community level rating, which is a measure of severity of disease and strain on the healthcare system, remains at low this week. The case rate for the past 7 days is the first indicator CDC is using. As of today, that case rate is 126 new cases per 100,000 people. The first hospital metric that determines our community level is the 7-day cumulative rate for new COVID-19 hospital admissions. Our current rate is 2.3 admissions per 100,000 residents. That meets the CDC criteria for low community level. Over the past 4 weeks, that rate has remained relatively stable. Although, as we noted, it's increased just a little bit over the past 5 days. The second hospital indicator is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients. This also relatively stable this past month. Today it's at 1.3%, and that also places us in the low community level. At this time, these metrics indicate there's less strain on our healthcare system. Next slide. We do continue to monitor community-wide and sector-specific indicators for early alerts that transmission and risk may be increasing. If a metric signals a possible area of concern, we can consider opportunities to implement protective strategies and to communicate information to residents and workers about the sensible steps that are needed to protect themselves and others. This week, all of our early alert signals, again, are of low concern, except for the percentage of specimens sequenced that are identified as a new variant or subvariant of concern. 88% of recent samples in LA County were identified as BA.2, an Omicron subvariant of concern, and I'll talk about this more in a minute. And although a number of the other early alert signals have not met threshold indicating elevated concern, I'm going to share information shortly that details increases across other signals. Next slide. As we continue to routinely sequence positive specimens, we can identify variants and lineages that may have significant public health impact. For specimens collected the week ending April 9th, Omicron accounted for almost 99% of all cases with sequenced specimens. The results for the remaining 1.4% of sequenced specimens are just pending. We don't have them yet. The Omicron BA.2 lineage is the predominant lineage, and it accounted for 88%, as I noted, of the sequenced specimens. That's a slight increase from the prior week. Nationally, BA.2 also remains the predominant subvariant, although there is increasing circulation of a newly identified sublineage strain, BA.2.12.1. For the week ending April 23rd, the CDC estimates that BA.2 accounted for 68% of sequenced specimens in the United States, with BA.2.12.1 accounting for approximately 29% of sequenced samples for that week. BA.2.12.1 sublineage is estimated to be 20 to 30% more transmissible than BA.2. And with that growth advantage, it could quickly become the dominant strain across the United States. In parts of the East Coast, BA.2.12.1 has been associated with increases in cases. And for the 7-day period that ended April 23rd, BA.2.12.1 did account for about 58%, so the majority of sequenced cases in New York, New Jersey, Puerto Rico, and the Virgin Islands. In LA County, 7% of sequenced specimens were identified as BA.2.12.1 for the week ending April 9th. That's up from 3% for the prior 7-day period, but I want to note we always have a lag here. The state did some modeling estimates, and they determined that BA.2.12.1 is likely to account for 50% of positive cases in California within a few days. We'll continue to track this sublineage in the county, and we'll follow research findings to assess whether this new subvariant, BA.2.12.1, leads to more severe illness or may be resistant to existing vaccines or therapeutics. To date, there's no information suggesting that it has a very different impact on illness severity, or it responds differently to our vaccines. But again, early days need more information. We're glad that while scientists continue to develop a more comprehensive understanding of how BA.2.12.1 interacts with individuals, that we can all be reminded to take prudent precautions to avoid getting infected and transmitting to others. Next slide. Increasing concentrations of the SARS-CoV-2 virus in wastewater also alerts us to the fact that community transmission may be increasing in certain areas. And we're monitoring wastewater concentration in 4 sewer systems across the county. For each of these 4 sewer systems, we consider a twofold or greater increase in the 10-day rolling average wastewater SARS-CoV-2 concentration when we compare it to the prior 14 days to be a cause for increased concern. If there is a twofold or greater increase in 1 or 2 of these wastewater systems, we'll consider this to be of medium concern. If there's a twofold increase in 3 or all 4 of the sewer systems, this would be, for us, of high concern. This slide shows the latest data from the Los Angeles County Sanitation District's Joint Water Pollution Control Plant, whose wastewater surveillance covers the southern and eastern parts of the county that are not part of the city of LA. The white line represents that 10-day rolling average of SARS-CoV-2 wastewater concentration. The orange dashed line is the average SARS-CoV-2 wastewater concentration from the prior 14 days. And that yellow dashed line that you see at the top here shows twice the average SARS-CoV-2 wastewater concentration from the prior 14 days, which is what, as we mentioned, would signal a cause for concern. And you can see here that although there have been some dips, there's been a fairly steady increase in average wastewater SARS-CoV-2 concentration since the end of February, with a steeper increase starting around mid-April. This increase leveled off a bit, and as of our last available data point, which was April 20th, the SARS-CoV-2 concentration was just below twice the average from 14 days before. Next slide. The slide looks at the data from the LA City Sanitation and Environment Agency. This covers most of the city of LA. Over the past several weeks, the average concentration of SARS-CoV-2 has also been increasing, and as of April 20th, was just shy of reaching the trigger of twice the average of the prior 14 days. Next slide. We're also able to include this week data from the LA County Sanitation District's Lancaster sewer system. This covers the city of Lancaster and the city of Palmdale, as well as some of the surrounding unincorporated areas. As you can see, SARS-CoV-2 concentration exceeded the 14-day average several times during our measurement period, but it never reached the level of twice the average from the prior 14 days. Despite this variability, this data nevertheless are going to suggest to all of us that SARS-CoV-2 cases in this area did also increase. That's similar to the findings we shared from the 2 other sanitation districts. The last sanitation district is Las Virgenes Municipal Water District. This covers part of West Valley near Ventura County border, and it didn't follow the same pattern. You actually see really not just a leveling off, but a small decline. In summary, though, the average SARS-CoV-2 wastewater concentration for all 4 sewer systems is below twice the average for the 14 days prior. In 3 out of our 4 sewer systems, however, we see that wastewater concentration increasing, and it's nearing twice the average. This suggests that community transmission is increasing in the areas that are covered by these sewer systems, which is a lot of LA County. And it's consistent with what we're reporting from other surveillance data. You know, I like to share this data because we all know that everybody is not necessarily having their test reports submitted to the Department of Public Health. So wastewater concentrations are another way for us to assess community transmission. Next slide. We also, as you know, are tracking outbreaks. In this case, I want to look for a second. I'll go to the next slide. I want to look for a second at outbreaks in congregate living situations. Here, we're going to look at skilled nursing facilities and among people experiencing homelessness. These are early alerts that also let us know if we need to take action to protect staff and residents, many of whom are particularly vulnerable to severe COVID-19 illness. For the latest 7-day reporting period that ended April 26, there were 6 new outbreaks that were open at our skilled nursing facilities, and 10 new outbreaks opened at sites serving people experiencing homelessness. 9 of those were in sheltered environments. While this is not yet a cause for increased concern, outbreaks in these settings, as you can see on this slide, have recently started to increase. The number of outbreaks in skilled nursing facilities likely again reflects that increase in ongoing transmission of COVID-19 in the community. COVID-19 in our SNFs really does pose a constant threat to residents since the virus often can have a devastating impact. With higher community transmission, there is a need for additional diligence at the nursing homes to limit exposures and transmission. Safety protections at these sites include universal masking, reinforcing the importance of and access to vaccinations and boosters for residents, compliance with the vaccination requirement for healthcare workers, and testing of visitors prior to indoor visitation. Similarly, increases in the outbreaks associated with people experiencing homelessness are related to increased community transmission. To reduce transmission, our shelters are implementing mitigation measures that include requiring use of and the provision of masks and respirators, recommending, or in some instances, such as when there are active outbreaks, requiring testing for selected staff and residents, assuring that there's capability for proper isolation and quarantine, and working closely with the Department of Public Health to provide support at facilities that are experiencing outbreaks. The next slide. Of course, with increased community transmission, we've also started seeing increased transmission now at work sites. And this week, we saw a doubling of reports from work sites seeing clusters of cases compared to the prior week. Among the 82 cluster reports that we received between April 20th and the 26th, the top 3 sectors represented were manufacturing sector, retail trade, and the information sector, which together accounted for about 55% of the total reports of clusters of cases. Among subsectors, the top 4 industries were food and beverage stores, electronics and appliance stores, transportation equipment manufacturing, and the motion picture and sound recording industries. We do greatly appreciate and rely on the partnerships with workers and employers to utilize safety protections at workplaces. And this, of course, is particularly important when community transmission is elevated, since there are many individuals whose work requires extensive exposures to others in indoor settings. Employers are reminded to offer all employees who work indoors in close contact with others a respirator for voluntary use if masking is optional. Next slide. Another setting experiencing small increases in outbreaks are at our TK through grade 12 schools. And this slide displays the small number of classroom-based outbreaks in schools. This does not include school-affiliated outbreaks that occur outside of the classroom setting, such as those that are associated with youth sports, with proms, and extracurricular activities, including theater, band, choir, and service clubs. And to note, we've not just seen increases in outbreaks associated with school-affiliated activities. It's also important to note that for the first time in a long time, some of these outbreaks have involved dozens of students. For the 7-day period that ended April 19th, there were 6 new classroom outbreaks open. They were all in elementary schools. This is a doubling of a very low number that we saw the prior week. And it's getting close to a threshold for elevated concern, which is when we reach 8 new classroom-based outbreaks opened in the last 7 days. The next slide. In addition to outbreaks at schools, we track testing volume, test positivity, and the number of cases. This slide shows school testing volume, represented by the blue bars, and test positivity, which is represented by the purple trend line. And you can look at this over time, going back to last November. As you can see, with just about all schools back in session, testing volume is again very high, with nearly 529,000 tests conducted between April 18th and the 22nd. And some of that was return to school testing as well after spring vacations. While test positivity rates remain low, as they have been since the end of the winter surge, over the past 2 weeks, we did start to see small increases in these rates as well. Next slide. The small increase in test positivity is matched with an uptick in cases among staff and students across elementary, middle, and high schools. The number of cases reported in students at elementary schools, middle schools, and high schools more than doubled between the 7-day period that ended March 27th and the 7-day period that ended April 17th. I want to note that we have a 1-week lag here since data for cases over the most recent week are still being reported. As students and staff have returned to campus after gathering and traveling for the spring holidays, we're likely to see additional increases. Thus, it's really important to take sensible safety steps now that can help limit transmission and outbreaks on the school campuses. This is especially true since we have the rise of a new and more infectious BA.2.12.1 subvariant, and we have now high community transmission levels. If routine testing is offered by the school, we strongly are encouraging parents to have their children participate so that those infected can quickly be identified and arrangements can be made for them to stay home until they're unlikely to spread COVID-19. Students and staff should also get tested if they have any COVID-like symptoms or they've been exposed to someone with COVID-19. With more potential exposures happening at schools, we want to remind parents that asymptomatic students remaining in school after an exposure to an infected person must wear a mask indoors for 10 days after their last exposure and should be tested as soon as possible to make sure they aren't infected. This is similar safety precautions that the general public takes. We're also continuing to strongly recommend indoor masking for everyone at schools. And now's a particularly good time for students and staff to wear high quality, well-fitting masks when indoors on school campuses. This is especially true if they traveled or attended gatherings with lots of other people over spring break. Next slide. Do continue to pay attention to our readiness to respond to a surge or other challenges, and this is our preparedness dashboard. It addresses making sure we have good access to vaccines, therapeutics, testing. We're adequately able to do surveillance, and we can respond to outbreaks. This week, again, all of our 13 measures, except for one, suggest satisfactory preparedness, and 8 of our 13 measures suggest outstanding preparedness. In addition, with the exception of 2 measures, all of our measures either stayed at current levels or they've improved from last week. The first measure that declined slightly was the percentage of eligible homebound residents referred to DPH and vaccinated who received their vaccine within 2 weeks from the date of referral. That dropped from 95% to 81%. Our team's working to improve the timeliness of delivering vaccines to homebound residents. We're assigning additional staff that can support this effort. So hopefully this number increases in the upcoming weeks. Next slide. There's also, as you can see, a decline in the percentage of positive specimens that were sequenced this week. We do aim to sequence at least 5% of positive case specimens per week, because this provides us with a good number of specimens to track what variants are circulating and causing illness in the county. And it helps us understand key characteristics of emerging variants. For the current measurement period, April 3rd through April 9th, 3% of positive specimens were sampled. The percentage of specimens that are sequenced is influenced by several factors, including the number of positive tests that meet the criteria for sequencing, and that sometimes fluctuates widely, the timeliness of submission and processing, and sequencing capacity. Notably, in March, the sequencing capacity in LA County declined significantly due to the loss of federal funding for a lab that was sequencing the majority of our specimens. We're glad to be able to report that we've established a new contract with a local laboratory that will be able to conduct additional sequencing. And so we hope that we're able to regain this adequate capacity very shortly. Next slide. We track the research and our own data on vaccine efficacy closely because we all know the effectiveness data has changed over time. The approved vaccines were initially not just providing superior protection from severe illness and death, they were also preventing at a very high rate infections. The proliferation recently of new strains of the virus with more ability to evade some of the vaccine protection against transmission has, for some, led to important questions of whether the vaccines are still providing us with sufficient protection to be considered an important tool for mitigating the impact of the virus. Looking at the totality of the information available allows us to confidently respond that yes, the approved COVID vaccines remain our best protection against severe illness and death associated with the SARS-CoV-2 virus. Those vaccinated and boosted remain significantly less likely to experience severe illness and death associated with Omicron and BA2. In LA County, recent data shows that those vaccinated are 4.5 times less likely to be hospitalized and 9 times less likely to die than those unvaccinated. And even though the differences aren't as large as they were in the past, those who are vaccinated are almost 2 times less likely to get infected than those not vaccinated. These differences are significant. And while we know that millions of LA County residents have some protection against COVID-19 because they were recently infected, this protection does not negate the advantages that vaccinations offer. There are a couple of compelling reasons for continuing to promote vaccines. We know that immunity to coronaviruses wanes over time, regardless of whether it was derived from prior infection or vaccination, making it likely that with continued circulation of easily transmissible variants, our immune systems will need to be boosted. Getting reinfected would be a much riskier strategy for maintaining a high level of protection than getting a booster or an additional dose. Emerging data also suggests that vaccines provide excellent protection to people who have already been infected with COVID-19. In a recent MMWR study, the receipt of COVID-19 mRNA vaccines, that's Moderna and Pfizer, protected against subsequent COVID-19 hospitalization for people who had been previously infected, and a booster dose provided the highest level of protection. And for those not yet vaccinated who have not yet been infected, getting infected can and does result in severe illness for lots of people. And for some, long COVID causes debilitating disease for many months. By contrast, vaccines have been shown to be very safe and reliably decrease the risk of severe illness, long COVID, hospitalizations, and death. And this has held up through all of the variants to date. Given the continued unpredictability of the virus and the established safety and efficacy of vaccines, our hope is that residents and workers will take advantage of the ample supply and easy access to vaccines and boosters to go ahead and get vaccinated and boosted. This allows us to interrupt cycles of transmission and protect those most vulnerable from the devastating effects of the virus. Next slide. Despite the known benefits of vaccines, as you can see here, relatively small numbers of children between 5 and 11 years of age have been vaccinated. On the slide, you could see we were making decent progress vaccinating this age group until about January, when the rates started to stagnate. And as of April 24th, about 37% of 5 through 11-year-olds received 1 or more doses of COVID-19. We do understand that some parents may be hesitant to vaccinate their children while COVID rates are relatively low and children have experienced less severe illness than adults. Other parents may not be sure whether COVID-19 vaccines are safe for young children. And still others would like their children to be vaccinated, but haven't really had the chance to get their children vaccinated yet. Here's what we'd like to be sure that parents know. Although most children aren't likely to have severe illness from COVID, some do become very ill and develop long COVID, and children are easily able to spread the virus to others, and some of those other people have become severely ill. Nationally, tens of thousands of children have been hospitalized with COVID-19, and tragically, over 900 children died from COVID since the start of the pandemic. And while these numbers for some may seem insignificant, they're certainly not insignificant to the parents and family members who have lost their children to COVID. And there aren't almost any other infectious diseases circulating in the United States that cause this many children to pass away, amplifying the need for us to do everything we can to reduce this unbearable tragedy. Moreover, there is increasing evidence that even healthy children are suffering from severe complications from COVID-19. In a recent MMWR study of hospitalizations among 5 to 11-year-olds, 3 out of 10 hospitalized children had no underlying health conditions. The data has also shown that children who are unvaccinated are at highest risk for severe illness. For instance, in that same MMWR study, 9 out of 10 children who were hospitalized were unvaccinated. And similar to recommendations for adults, vaccines are recommended for children ages 5 and older, even if they had COVID-19. Children who were already infected may have some natural immunity, but we can't predict how strong or long that protection will be. So vaccinations for children, similar to vaccinations for adults, are the best and safest choice for building and protecting immunity. Children who had COVID-19 should wait until they've recovered from being sick and have completed their isolation period to get vaccinated. With summer approaching and the possibility of more infectious variants, children are likely to have additional opportunities to get exposed to COVID-19. Getting your child vaccinated or caught up if they're missing any doses can increase their protection and increases the protection for vulnerable children and people around them. And it's great to do this before children are traveling or participating in their summer activities, including summer camps, where they may be mingling with people from many other communities. There is a lot of information out there about vaccines, and I know it's difficult to sort through all of the information. We do ask that parents with questions about vaccines or boosters or want to make an appointment to get a free vaccine to speak with their child's provider. If you don't have easy access to a provider, please visit vaccinatelacounty.com or vacunatelosangeles.com or call our COVID-19 information line at 833-540-0473, open 8 in the morning to 8:30 at night every single day. Next slide. Finally, I do want to close with a reminder about masking requirements and recommendations. With high community transmission and the potential for more infectious variants to circulate in the county, one of the best and easiest things we can do to prevent infection is to wear a well-fitting, high-filtration mask or respirator when indoors around others. Masks are required under local or state rules in select high-risk settings, even if you're fully vaccinated and boosted. Masking is required by everyone, staff, visitors, patients, and residents in healthcare settings, as well as in long-term care settings, senior care facilities, shelters and cooling centers, correctional facilities, and detention centers. Masks are also required for everyone 2 years of age and older, regardless of COVID-19 vaccination status, in all public transit within LA County and in LA County indoor transportation hubs. Traveling on public conveyances increases a person's chance of getting and spreading COVID-19 because we are bringing lots of people in close contact with others, often for long periods of time, often in crowded settings where ventilation may be inadequate. When people wear a well-fitting mask or respirator, they protect themselves and those around them, and they keep travel and public transportation safer for everyone. Masks are required on commuter trains, subways, buses, taxis, and ride shares in LA County. Masking is also required in indoor transportation hubs in LA County, including airport and bus terminals, train and subway stations, marina or other indoor port terminals, or any other indoor area that serves as a transportation hub. And as always, a reminder that businesses and venues have the discretion to require masking for the protection of their workers and patrons, and we ask everyone to be respectful of the ability for those businesses to add in those layers of protection. Although it's not required, masks and respirators are strongly recommended in most other indoor public places for everyone 2 and older. This includes businesses, restaurants, entertainment sites, such as movie theaters, indoor meeting sites, and in educational settings such as colleges or universities, schools, or daycare. For your own protection and the protection of others, we continue to ask everyone to consider wearing masks in these indoor settings, especially if you're at higher risk for severe illness or you live or you work with someone who is. In closing, since the beginning of the pandemic, we've all had to make choices about how to best protect ourselves and others from COVID-19. With cases on the rise, the potential for more contagious variants, and lots of opportunities to be exposed, this is a great time to make a choice to get vaccinated or boosted and to wear a mask or respirator when you're indoors and around others. Thanks, and I'll now take your questions.
Thank you so much, Dr. Ferrer. As a reminder, if you have a question, you may chat me, the host, or you can use the hand icon. Our first question comes from Marla Tejas from Fox 11. Marla, you're unmuted.
Oh, thank you so much, Dr. Ferrer, for taking my questions. I'm going to start by asking you, so going back to a week ago, you made the big announcement about the travel mask mandate on public transportation. As you know, that was big news. There doesn't seem to be that big headline today from this news conference, from this briefing, I should say. Do you foresee, though, given the rise in cases and especially after kids coming back from spring break and more outbreaks among students, that masking will be put back in place in schools? What is the specific metric that would bring back masks for schools and for the public? And this, of course, in lieu of BA.2,
.12.1.
Yeah, thank you.
No,
and then also, name. I know. And then Paxlovid, it's making some news this week because of our vice president being treated with it.
Yep.
I know you have your test to treat program. How's that going? Are patients taking advantage of it? How readily, how accessible is Paxlovid for just the average person out there? And then lastly, Dr. Fauci went on the record this week of saying that we're out of the pandemic phase of the pandemic, that it's over, and then he backtracked a little bit. How do you see us? What is the state of the pandemic? Thank you.
Okay. Yeah, maybe Marla, thanks for those questions. Let me start with the last question. I think and I don't know that he backtracked. I think he tried to explain exactly what he was referring to. And I don't think Dr. Fauci is saying anything different than any other public health leader has been saying for the last few weeks. We're in a different phase. And it's a much more hopeful phase. And we're all grateful for the work everyone's doing that got us to this phase. You know, people getting vaccinated, people getting boosted, as you noted, people taking advantage of using our therapeutics to keep themselves from developing severe illness, people taking care of each other, keeping their masks on when there's higher risks. This all allows us to be in a different phase. You know, here in LA County, we call it post-surge. I think the state Department of Public Health here and Dr. Galley at the state level have been clear that this is an unpredictable virus. We're going to have to remain prepared. But at every stage, we've been able to develop really powerful tools that help us mitigate against the worst outcomes associated with COVID-19. And that continues to be the reality. So I share the hopefulness that I think Dr. Fauci was really amplifying by noting that, yes, things are very different right now than they were even during the height of the Omicron surge. I think Dr. Fauci was also clear to say the virus is still here. The pandemic is not over. We enter in these different phases, and then we can use different tools that are appropriate for the phases that we're in. So I think that gets me to your other two questions is, you know, what's the role of requirements for masking and what do we think is likely to happen in the future? So let me just start with, you know, the distinctions that are made now, and this is across the state, is there are some settings where there's higher risk for transmission and or there's higher risk to people in those settings where masking continues to be required. And that's why I wanted to go over that list. It's not just transportation. We have a whole host of other places where people are keeping their masks on because they're keeping each other safe in these higher risk settings. And we're grateful for the high level of cooperation there. Here in LA County, that includes, as you noted, indoor transit corridors and our transportation hubs. I think in terms of the other set of sites where we all interact with each other, we've continued to strongly urge everyone to keep those masks on. I think we're comfortable now continuing with that strong recommendation. I want to note that in any site, businesses, offices, factories, schools, where we've seen outbreaks as a method of controlling that outbreak, there have been times where people in a particular setting have already been told they had to put their mask back on. And as I noted earlier, for people who wish to not do a standard, customary quarantine where you've had an exposure and you now stay home, that's also permitted, provided you're going to wear your mask every time you're indoors and around others, and you're going to get yourself tested to make sure you're not asymptomatic and infected. So for asymptomatic people without symptoms who've had an exposure, they don't need to stay home in quarantine provided they're wearing their mask. So I want to note there's some people in lots of different settings wearing their mask appropriately because they're adhering to the public health safety protocol that's in place around how to best manage the time period of 10 days from your last exposure so that you keep each other safe during that time period. Do we have, do we predict anytime soon sort of changing direction? No. I mean, I think you've seen us continue to move in the direction of making sure that people have easy access to vaccinations and boosters. We're building out a vast network to make sure people can get therapeutics, and I'll answer the question on Paxlovid in a second. And we're relying on the fact that a strong recommendation is exactly that. I think, many people will read a strong recommendation as exactly what it's meant to be. Please keep your masks on. There is one trigger that I've noted before, at which point the county will, in fact, automatically revert to a requirement that everybody mask indoors, and that is if we were to move to high community level under the CDC framework. Remember, that framework is assessing stress on the healthcare system. And once there's a lot of stress on the healthcare system, we're all going to need to be wearing our masks. And, that is the one automatic trigger. Otherwise, we're looking at information sector by sector, paying a lot of attention to our early alert signals and really working with our partners to do the very best we can to protect ourselves. But I want to point out that masking is, at most an annoyance, and really, particularly masking to take care of other people who are much more vulnerable seems like a very good idea to me. So I'm going to continue to encourage that people keep those masks on in those indoor settings where they're in contact with other people. In terms of Paxlovid, thanks for that question. I think every opportunity we have to remind the general public that if you test positive, you need to check in with your provider. And if you don't have a provider, use our telehealth service and check in, do an assessment about whether you're a good candidate for one of the new therapeutics. As you noted, the vice president was prescribed Paxlovid. I want to note you have to get a prescription, but we've made it super easy. People can do it with a telehealth visit from their home. You can have your test result that you took in your house with your over-the-counter kit. You can talk to a clinician about your history, your medical history. It has to be a full assessment. And then if you are a good candidate, that medication will either be sent to a pharmacy that you select, or it'll be sent overnight mail to your home. So again, we want to make it super easy for people. There's also about 600 pharmacies and sites that distribute oral therapeutics across the county. You can go on our website and see those sites. But these are by prescription only. So I think the hurdle for many people has been, you need to get these medications quickly once you've started developing symptoms and or have tested positive. So you want to be able to make sure you know how to reach your provider quickly should that happen. And if you can't reach your provider, please call us at the DPH telehealth service, and we're going to be happy to help you out. So thanks for those questions. We'll take the next question.
Our next question comes from Ron Lynn from the LA Times. Ron, you're unmuted.
Hi, Dr. Ferrer. Thanks so much for talking with us. Really appreciate it. Our questions today are about LAUSD, a crystal ball question, and the so-called decoupling of cases and hospitalizations. So first, the LAUSD schools chief has recommended delaying enforcement of a vaccine requirement for school children, and he's suggesting that it align with out of the state, which at the earliest would go into effect more than a year from now. This comes as you mentioned, that only a third of children aged 5 to 11 in LA County have completed their primary vaccination series. And there's some concern about how feasible it would be to implement a requirement if so many parents are hesitant about getting their kids vaccinated. Are you disappointed by the superintendent's recommendation? And can you share your thoughts on whether you still support a vaccine requirement for COVID for school children? Second, for some people, this pandemic has alternated between two phases. Personally, either everything is terrible or everything is fine. With what you're seeing in hospitalizations and in wastewater, are we headed into a second Omicron surge, swell wave? How would you characterize where we're headed? And then finally, last week we saw that cases were up, but hospitalizations were flat. And at the time, you mentioned that hospitalizations could rise soon because of the customary lag, or it could be that there are fewer hospitalizations for every case because of higher levels of vaccination and recent immunity from Omicron. Are we now at a place where it doesn't really matter how many cases we have, so long as hospitals remain in good shape, or nah? Thanks so much.
Yeah, thanks so much. Let me just start with the last question. I think it's a great question that everyone's struggling to answer is, what's the relationship between cases and hospitalizations, and do we really even want to worry about that relationship? First of all, as I've noted, we have less than perfect information about how many people are in fact infected. We've never really had perfect information on this. So we're relying on what we're seeing in surveillance on testing, but also on what we're seeing in wastewater concentrations. Obviously, having a virus that causes relatively mild illness doesn't result in people ending up hospitalized or seriously ill with disability later on from long COVID, or tragically dying, is a very different scenario than having a virus that circulates and causes a lot of debilitating and severe illness can overwhelm our hospitals. I think the concern right now, this would be my concern, is with so many new variants cropping up, we just don't know whether or not we're really on this trajectory where all we're going to see is milder and milder illness. And I would just suggest that we not, guess on this, be overly optimistic. That we in fact recognize this is a virus that mutates both fairly rapidly but also fairly dramatically, which changes both the ability for our vaccines to provide a level of protection that absolutely I think is contributing to the lower rates of hospitalization and deaths. So, I say, we still have to track on cases. We still have to worry about cases. We still have to understand the relationship between people getting infected and who goes on to experience the worst of the outcomes. And we also have to acknowledge that you don't want unchecked transmission, which leads to the possibility of more variants of concern. So we're going to have to worry about cases. I know lots of people are saying, I don't want to pay attention. Don't tell me what the numbers are. I don't care. But the numbers matter. And in practical terms, it also matters because we do want to continue to pay attention to our ability to reduce transmission wherever it's feasible, which means we need to know when there are outbreaks, how to in fact make sure that we don't again see a lot of unchecked transmission. Lots of people don't end up in the hospital, but certainly they end up feeling sick, needing to take time off from work, and they, during their infectious period, can infect others. So I'm going to say not time to stop worrying about cases at all. I don't really actually, I don't have a hard time understanding logic that would have us in the middle of a pandemic not worrying about transmission. And I don't know very many people who are saying we have reached a point where we don't need to worry about transmission. I think it is important to pay a lot of attention to the changing nature of what happens when people get infected, and then use different strategies depending on what we find out. But we still need to do everything we can to keep transmission as low as possible. Is there second surge, on the horizon? I hope not. I mean, we've definitely seen an increase. We're seeing an increase in cases that's pretty significant. We started to see a small increase in hospitalizations. My hope is that, again, we've got a few things that are happening at the same time here. We've removed some of the safety protection measures from being widely adopted in a whole host of settings. And we also had our spring holidays and our spring break. I'm hoping that this increase that we're seeing stabilizes fairly soon without going much higher. And that, again, we continue, because we have a lot of people vaccinated, we have a lot of people getting boosted, and hopefully more people will take advantage of that. We've got therapeutics. We're minimizing stress on our healthcare system. But you have to look at the data across the country. I mean, the East Coast is seeing a significant rise now in hospitalizations, and we don't have enough information about this new variant of concern, BA.2.12.1. So let's continue to be cautious. Let's continue to follow the data. Let's continue to be prepared to take appropriate measures depending on what we're learning and seeing, both in other parts of the country and the world, and what we're experiencing here in our county. I always applaud our education partners. They have super hard jobs. I think, again, making sure that mandates for children around vaccinations are tied to that final approval process is a sensible strategy, as long as we're not seeing overwhelming death and devastation by the pandemic. I think, were we back to sort of our pre-vaccine days where, that first winter surge, we had, I don't know, almost 6% of folks infected ending up hospitalized. We had, or we have what we had during Omicron, overwhelming numbers of people getting sick and requiring a lot of care. We might need to revisit what to do with our vaccination mandates. But in general, I'm supportive of, when you have that full approval from the FDA, adding COVID vaccines to the long list of vaccinations that are required for students attending our schools. I think that's sensible. But I recognize that it's also sensible for LAUSD to align with the timeline that the state has laid out. So thanks for that.
That concludes our question and answer period. Any closing remarks, Dr. Ferrer?
No, just thanks a lot, everyone. Look forward to continuing to work with you. And again, deeply appreciate all you're doing to make sure people stay well informed. Thanks a lot. We'll talk again next week.
Any additional media questions can be directed to our media inbox at media@ph.lacounty.gov. If you stick around, we'll have Spanish remarks in just a few minutes. Hi there, Jackie. Would you like to get started?
Yeah, that'd be great. Go ahead and. Okay, you ready?
Your slides ready. All right. Good afternoon, everyone. Thank you so much for joining us for the Spanish portion of today's briefing. Today is April 28th. We have Jackie presenting. Jackie, whenever you're ready.
Great, thank you. Buenas tardes y gracias por acompañarnos durante la sesión informativa de hoy. Comenzaremos con una actualización, repasaremos los resultados actuales de nuestras señales de alerta temprana y medidas de preparación, discutiremos los beneficios de la vacunación y terminaremos con un poco de información acerca del uso de mascarillas. First slide, please. Durante la última semana siguió aumentando el número de casos y hoy informamos 2.335 casos nuevos. El promedio de casos nuevos diarios informados durante los últimos 7 días aumentó a 1.764 en comparación con el promedio de 1.261 casos nuevos que informamos el jueves pasado. Esto es un aumento del 40% en solo una semana. Esta semana, el promedio de 7 días de nuestra tasa de casos diarios también aumentó a 17 casos nuevos por cada 100,000 residentes, a comparación a los 12 casos nuevos por cada 100,000 del jueves pasado. Nuestra tasa de casos semanales actualmente es de 12 por cada 100,000 residentes, cual significa que el condado de Los Ángeles está nuevamente experimentando una alta tasa de transmisión. El promedio de la tasa diaria de positividad de la prueba permanece relativamente estable en el 1.8%. Esta semana, las hospitalizaciones comenzaron a subir lentamente, con pequeños aumentos cada día esta semana en el número de personas hospitalizadas. Hoy hay 249 pacientes con COVID actualmente hospitalizadas en el condado de Los Ángeles. Dado que las muertes suelen ser un indicador rezagado, seguimos viendo números de muertes diarias relativamente bajos, con un promedio de 7 muertes diarias informadas durante la última semana. Sabemos que cada persona que ha fallecido debido a COVID deja atrás familiares y otros seres queridos que están afligidos por su pérdida y extendemos nuestras más profundas condolencias y esperanzas de fortaleza y consuelo a todos aquellos que han perdido a alguien por COVID. Next slide, please. Como siempre, nos ayuda a ver a nuestros indicadores a lo largo del tiempo. En este gráfico puede ver las tendencias sobre las últimas 4 semanas de nuestro promedio de 7 días de casos diarios por fecha de informe, el promedio de 7 días de hospitalizaciones diarias por fecha de admisión y el promedio de 7 días de muertes diarias por fecha de informe. Aunque nuestro promedio actual de 7 días de casos diarios, la línea verde, está muy por debajo de lo que vimos durante la oleada invernal, ha aumentado de manera constante desde fines de marzo. Para el periodo de 7 días que termina hoy, un promedio de más de 1.700 casos fue informado cada día. Mientras que de día en día la tasa de aumento es relativamente pequeña, hoy el promedio de 7 días del número de casos diarios es casi 3 veces el promedio que vimos hace un mes, el 28 de marzo. Mientras que el promedio de 7 días de la tasa de hospitalización, la línea anaranjada, ha aumentado levemente durante las últimas 2 semanas, se mantuvo relativamente baja durante el último mes. Las tasas de hospitalización están estables y pueden reflejar el retraso habitual entre los casos y las hospitalizaciones, así como los efectos protectores de las vacunas, las dosis de refuerzo y el medicamento. Y como mencionamos anteriormente, el promedio de 7 días de muertes informadas a diario, la línea azul ha continuado a bajar y alrededor de 7 muertes diarias es casi un tercio del promedio de hace un mes. Next slide, please. Nuestro nivel comunitario general es una medida de la gravedad de la enfermedad y de qué tan abrumado está nuestro sistema de atención médica.
y permanece bajo esta semana. La tasa de casos de los últimos 7 días es el primer indicador que utilizan los CDC para determinar nuestro nivel comunitario junto con 2 indicadores de hospital. A partir de hoy, la tasa de casos del condado de Los Ángeles es de 126 casos nuevos por cada 100,000 habitantes. El primer indicador de hospital que determina nuestro nivel comunitario es la tasa agregada de 7 días de nuevas admisiones al hospital por COVID-19. Nuestra tasa actual de 2.3 admisiones por cada 100,000 habitantes cumple con los criterios de los CDC para el nivel comunitario bajo. El segundo indicador de hospital es el promedio de 7 días de la proporción de camas de hospitalización que tienen personal y están ocupadas por pacientes con COVID. Esta se ha mantenido relativamente estable este mes y hoy es del 1.3%, que también se considera que indica un nivel comunitario bajo. Ambos indicadores reflejan que en este momento está menos abrumado el sistema médico. Next slide, please. También continuamos vigilando un grupo de indicadores de alerta temprana a nivel comunitario y específicos para ciertos sectores para dejarnos saber si las condiciones relacionadas con la transmisión y el riesgo pueden estar aumentando. Si un indicador sugiere una posible preocupación, consideramos las oportunidades para implementar medidas protectoras y comunicar información a residentes y trabajadores acerca de los pasos sensibles que pueden tomar para protegerse a sí mismos y a los demás. Esta semana, todas nuestras señales de alerta temprana son de preocupación bajo, excepto una: el porcentaje de muestras secuenciadas que se identifican como una nueva variante o subvariante de preocupación. 88% de las muestras recientemente secuenciadas en el condado de Los Ángeles se identificaron como BA.2, una subvariante de preocupación de Omicron, de cual hablaremos en más detalle en un minuto. Y aunque varias de las otras señales de alerta temprano no han alcanzado los niveles que indican una preocupación elevada, en breve compartiremos información detallando los aumentos a través de las otras señales. Next slide, please. Mientras continuamos la secuenciación rutinaria de muestras positivas, podemos identificar variantes y linajes que podrían tener un impacto significativo en la salud pública. Las muestras secuenciadas que fueron recolectadas durante la semana que terminó el 9 de abril, Omicron representó el 98.6% de los casos con muestras secuenciadas. Resultados para el 1.4% de los casos con muestras secuenciadas restantes están pendientes. El linaje Omicron BA.2 es el linaje predominante, representando el 88% de las muestras secuenciadas, un aumento leve desde la semana anterior. A nivel nacional, BA.2 también sigue siendo la subvariante predominante, aunque hay una circulación creciente de un sublinaje recientemente identificado, BA.2.12.1. Para la semana que terminó el 23 de abril, los CDC estiman que BA.2 representó el 68% de las muestras secuenciadas en los Estados Unidos y BA.2.12.1 representó aproximadamente el 29% de las muestras secuenciadas esa semana. Se estima que el sublinaje BA.2.12.1 perdón, es un 20 a 30% más transmisible que BA.2 y con una ventaja de crecimiento podría convertirse rápidamente en la cepa dominante en los Estados Unidos. En partes de la costa este, BA.2.12.1 se ha asociado con aumentos en casos durante el periodo de 7 días que terminó el 23 de abril. BA.2.12.1 representó el 58% de los casos secuenciados en Nueva York, Nueva Jersey, Puerto Rico y las Islas Vírgenes. En el condado de Los Ángeles, el 7% de las muestras secuenciadas se identificaron como BA.2.12.1 durante la semana que finalizó el 9 de abril, frente al 3% del periodo de 7 días anterior. El Estado, a través de estimaciones de modelos, estima que BA.2.12.1 va a representar el 50% de casos positivos dentro de unos días. Vamos a continuar vigilando este sublinaje en el condado y seguiremos los hallazgos de la investigación para evaluar si BA.2.12.1 conduce a una enfermedad más grave o puede ser resistente a las vacunas o tratamientos actuales. Mientras los científicos continúan desarrollando una comprensión más completa de cómo BA.2.12.1 interactúa con las personas, les recomendamos a los residentes y a los trabajadores que tomen precauciones prudentes para evitar infectarse o transmitírselo a otros. Next slide, please. Las concentraciones crecientes del virus SARS-CoV-2 en las aguas residuales nos alertan sobre la posibilidad de que la transmisión comunitaria en un área determinada esté aumentando. Y estamos vigilando la concentración de aguas residuales en 4 sistemas locales a través del condado. Para cada uno de estos 4 sistemas locales, vamos a considerar que un aumento del doble o mayor en el promedio de 10 días de la concentración de SARS-CoV-2 en aguas residuales en comparación con los 14 días anteriores es motivo de mayor preocupación. Si hay un aumento del doble o mayor en 1 o 2 de estos sistemas, lo vamos a considerar de preocupación media. Si hay un aumento del doble en 3 o en los 4 de estos sistemas, lo vamos a considerar de preocupación alta. Este gráfico muestra los datos más recientes de los distritos de saneamiento del condado de Los Ángeles, la planta conjunta para el control de la contaminación del agua, cuya vigilancia de aguas residuales cubre las partes sur y el este del condado que no forman parte de la ciudad de Los Ángeles. La línea blanca representa el promedio móvil de 10 días de la concentración de SARS-CoV-2 en aguas residuales. La línea discontinua anaranjada muestra el promedio de la concentración de SARS-CoV-2 en aguas residuales de los 14 días anteriores. Y la línea discontinua amarilla muestra el doble del promedio de la concentración de SARS-CoV-2 en aguas residuales de los 14 días anteriores, que, como se mencionó, es lo que indica motivo de preocupación. Como puede ver aquí, aunque ha habido caídas, ha habido un aumento bastante constante en el promedio de la concentración de SARS-CoV-2 en las aguas residuales desde fines de febrero, con un aumento más pronunciado a partir de mediados de abril. Desde entonces, este aumento se estabilizó y a partir de nuestro último punto de datos disponible, el 20 de abril, la concentración de SARS-CoV-2 estaba justo por debajo del doble del promedio de los 14 días anteriores. Next slide, please. Este gráfico muestra los datos de la Agencia Ambiental y de Saneamiento de la Ciudad de Los Ángeles, cuya vigilancia de aguas residuales cubre la mayor parte de la Ciudad de Los Ángeles. En las últimas semanas, el promedio de la concentración de SARS-CoV-2 ha ido aumentando y a partir del 20 de abril estuvo a punto de alcanzar el doble del promedio de los 14 días anteriores. Next slide, please. Esta semana podemos incluir datos del sistema local de Lancaster, cual forma parte del distrito de saneamiento del condado de Los Ángeles, que cubre la ciudad de Lancaster y la ciudad de Palmdale, así como algunas áreas cercanas no incorporadas. Como puede ver, la concentración de SARS-CoV-2 superó el promedio de 14 días varias veces durante nuestro promedio de medición, pero nunca alcanzó el nivel del doble del promedio de los 14 días anteriores. A pesar de esta variabilidad, estos datos sugieren que los casos de SARS-CoV-2 en el área han aumentado. de manera similar a los hallazgos compartidos de los otros distritos de saneamiento. Next slide, please. Los resultados de los distritos municipales de agua de las Vírgenes, cuya vigilancia de aguas residuales cubre parte del Valle Oeste, cerca de la frontera del condado de Ventura, no siguen un patrón similar con una pequeña disminución observada recientemente. En resumen, mientras que el promedio de la concentración de SARS-CoV-2 en aguas residuales para los 4 sistemas locales está por debajo del doble del promedio de los 14 días anteriores, en 3 de nuestros 4 sistemas, la concentración de SARS-CoV-2 en aguas residuales está aumentando y se acerca al doble del promedio de los 14 días anteriores. Esto sugiere que la transmisión comunitaria está aumentando en las áreas cubiertas por esos sistemas locales, lo cual es consistente con lo que informamos de otros datos de vigilancia. Next slide, please. Los brotes en las instalaciones de vivienda congregada, como centros de enfermería especializada y entre personas sin hogar, sirven como alertas tempranas que pueden identificar que se necesita tomar acción para proteger al personal y a los residentes, muchos de los cuales pueden ser particularmente vulnerables a la enfermedad grave por COVID-19. Para el periodo de informe de 7 días que terminó el 26 de abril, se abrieron 6 nuevos brotes en centros de enfermería especializada y 10 nuevos brotes en sitios que proveen servicios a personas sin hogar, 9 de los cuales están en entornos de albergues. Mientras no es motivo de mayor preocupación todavía, los brotes en estos entornos, como puede ver en este gráfico, han comenzado a aumentar recientemente. La cantidad de brotes en centros de enfermería especializada probablemente refleja la transmisión continua de COVID en la comunidad. Incluso cuando hay niveles más bajos de transmisión comunitaria, el COVID representa una amenaza constante para las personas que viven en los centros de enfermería especializada, ya que el virus se introduce en los centros de enfermería especializada principalmente por los visitantes y los trabajadores de salud que viven en la comunidad. Con una mayor transmisión comunitaria ahora, existe la necesidad de ser más diligentes en los hogares de personas mayores para limitar la exposición y la transmisión. Las medidas de seguridad incluyen el uso universal de mascarillas, resaltar la importancia del acceso a las vacunas y dosis de refuerzo para los residentes y el cumplimiento del requisito de vacunación para los trabajadores de salud y las pruebas para los visitantes antes de las visitas en interiores. De manera similar, es probable que los aumentos en los brotes entre las personas sin hogar estén asociados con una mayor transmisión en la comunidad. Para reducir la transmisión, los albergues están implementando medidas de mitigación que incluyen exigir el uso y el suministro de mascarillas y respiradores, recomendar o, en algunos casos, como durante brotes activos, exigir pruebas para el personal y algunos residentes seleccionados, garantizar el aislamiento y la cuarentena adecuados y hacer que salud pública proporcione apoyo en las instalaciones que tengan brotes. Next slide, please. Con una mayor transmisión en la comunidad, también comenzamos a ver una mayor transmisión en los sitios de trabajo y esta semana vimos un doble de los informes en sitios de trabajo que vieron grupos de casos en comparación con la semana anterior. Entre los 82 informes recibidos entre el 20 y el 26 de abril, los 3 principales sectores representados fueron fabricación, comercio minorista e información, que juntos representan el 55% del total de informes de grupos de casos. Entre los subsectores, las 4 industrias principales fueron tiendas de alimentos y bebidas, tiendas de electrodomésticos y productos electrónicos, fabricación de equipos de transporte e industrias de grabación de sonido y películas.
Agradecemos a las alianzas entre trabajadores y empleadores para utilizar protección de seguridad en los sitios de trabajo. Esto es particularmente importante cuando la transmisión comunitaria es elevada, ya que hay muchas personas cuyo trabajo requiere exposiciones extensas a otras personas en entornos cerrados. Recordamos a los empleadores que ofrezcan un respirador para uso voluntario a todos los empleados que trabajan en interiores en contacto cercano con otros. Next slide, please. Otro entorno que está viendo pequeños aumentos en los brotes son las escuelas de kinder de transición al 12 año, y este gráfico muestra la cantidad de brotes en las aulas de las escuelas. Esto no incluye los brotes relacionados con la escuela que ocurren fuera del aula, como los casos asociados con deportes juveniles y actividades extracurriculares, como teatro, banda, coro o clubes de servicio. Y para tener en cuenta, no solo hemos visto aumentos en los brotes asociados con actividades afiliadas a la escuela, algunos de estos brotes han involucrado a decenas de estudiantes. Durante el periodo de 7 días que terminó el 19 de abril, se abrieron 6 nuevos brotes de aula, todos en escuelas primarias. Esto es el doble del número de los brotes abiertos la semana anterior y se acerca al nivel de mayor preocupación, que son 8 nuevos brotes en el aula abiertos en los últimos 7 días. Next slide, please. Además de los brotes, también vigilamos la cantidad de pruebas, la positividad de las pruebas y la cantidad de casos en las escuelas. Este gráfico muestra la cantidad de pruebas escolares, las barras azules, y la positividad de las pruebas, la línea de tendencia morada, a lo largo del tiempo. Como puede ver, con casi todas las escuelas nuevamente en sesión, la cantidad de pruebas es muy alta, con casi 529,000 pruebas realizadas entre el 18 y el 22 de abril. Si bien las tasas de positividad de las pruebas han sido bajas desde el final de la oleada invernal, durante las últimas 2 semanas comenzamos a ver pequeños aumentos en las tasas. Next slide, please. El pequeño aumento en la positividad de las pruebas coincide con un aumento en los casos entre el personal y los estudiantes de las escuelas primarias, intermedias y secundarias. La cantidad de casos informados en estudiantes de escuelas primarias, secundarias y preparatorias aumentó más del doble entre el periodo de 7 días que terminó el 27 de marzo y el periodo de 7 días que terminó el 17 de abril. Tenga en cuenta que estos datos representan un retraso de una semana, ya que todavía se están informando los casos de la semana más reciente. En cuanto hayan regresado los estudiantes y el personal a sus escuelas, después de reunirse y viajar durante las vacaciones de primavera, es probable que veamos aumentos adicionales. Por lo tanto, es importante tomar medidas de seguridad sensatas ahora para limitar la transmisión y los brotes escolares. Esto es especialmente cierto dado el surgimiento de la nueva y más infecciosa subvariante BA.2.12.1 y niveles más altos de transmisión comunitaria. Si la escuela ofrece pruebas de rutina, recomendamos fuertemente a los padres que hagan que sus hijos participen para poder rápidamente identificar a las personas enfermas y se pueden hacer arreglos para que se queden en casa hasta que sea poco probable que propaguen el COVID. Los estudiantes y el personal también deben hacerse la prueba si tienen síntomas similares a los de COVID o si han estado expuestos a alguien con COVID. Con más exposiciones potenciales en las escuelas, se les recuerda a los padres que los estudiantes que tienen síntomas y que han seguido en la escuela después de una exposición a una persona infectada deben usar una mascarilla en los interiores de la escuela por 10 días después de su última exposición y deben hacerse la prueba lo más antes posible para asegurarse de que no estén infectados. También seguimos fuertemente recomendando el uso de mascarillas en interiores para todos en las escuelas. Y ahora es un momento particularmente bueno para que los estudiantes y el personal usen mascarillas de alta calidad y bien ajustadas cuando estén en el interior de los sitios escolares, especialmente si viajaron o asistieron a reuniones durante las vacaciones de primavera. Next slide, please. Continuamos evaluando nuestra preparación para responder a un aumento repentino u otro desafío mediante el seguimiento de los indicadores de preparación que abordan el acceso a vacunas, medicamento y pruebas, vigilancia y nuestra respuesta a brotes. Esta semana, todas nuestras 13 medidas, excepto una, sugiere una preparación satisfactoria y 8 de las 13 medidas sugieren una preparación sobresaliente. Además, con la sección de 2, todas las medidas se mantuvieron en los niveles actuales o mejoraron desde la semana pasada. La primera medida que disminuyó fue el porcentaje de residentes elegibles que están confinados en su hogar, que fueron referidos a salud pública y vacunados y que recibieron la vacuna dentro de las 2 semanas después de ser referidos, que disminuyó del 95% al 81%. Nuestro equipo está trabajando para mejorar la puntualidad de la entrega de vacunas a los residentes confinados en sus hogares mediante la asignación de personal adicional para apoyar este esfuerzo. Y con suerte, este número aumentará en las próximas semanas. Next slide, please. También hubo una disminución en el porcentaje de muestras positivas secuenciadas por semana. Nuestro objetivo es secuenciar el 5% o más de muestras de casos positivos por semana, ya que estos nos proporcionan muestras adecuadas para rastrear qué variantes circulan y causan enfermedades en el condado y para comprender las características de las variantes emergentes. Para el periodo de medición actual del 3 al 9 de abril, se tomaron muestras del 3% de las muestras positivas. El porcentaje de muestras que se secuencian están influenciados por varios factores, incluido el número de pruebas positivas que cumplen con los criterios para la secuenciación, que fluctúa ampliamente, la puntualidad de la presentación y el procesamiento y capacidad de secuenciación. En particular, en marzo, la capacidad de secuenciación en el condado de Los Ángeles disminuyó significativamente debido a la pérdida de fondos federales para un laboratorio que estaba secuenciando la mayoría de las muestras. Estamos estableciendo un nuevo contrato con un laboratorio local para realizar secuenciaciones adicionales y esperamos recuperar la capacidad adecuada en breve. Next slide, please. Seguimos de cerca la investigación y nuestros propios datos sobre la eficacia de la vacuna porque los datos de eficacia han cambiado con el tiempo. Inicialmente, las vacunas aprobadas no solo brindaban una protección superior contra enfermedades graves y la muerte, sino que también prevenían a un ritmo muy alto las infecciones. La transmisión de nuevas cepas del virus que tienen más capacidad de evadir parte de la protección de la vacuna ha resultado en que algunas personas se preguntan si las vacunas todavía nos brindan suficiente protección para mitigar el impacto del virus. Observar la totalidad de la información disponible nos permite responder con confianza que sí, las vacunas aprobadas contra el COVID siguen siendo nuestra mejor protección contra enfermedades graves y muertes asociadas con el virus SARS-CoV-2. Las personas que están vacunadas y que tienen su vacuna de refuerzo tienen significativamente menos probabilidades de sufrir enfermedades graves y muertes asociadas con Omicron y BA.2. En el condado de Los Ángeles, datos recientes muestran que las personas vacunadas tienen 4.5 veces menos probabilidades de ser hospitalizadas y 9 veces menos la probabilidad de morir que las personas no vacunadas. Y aunque las diferencias no son tan grandes, las personas vacunadas tienen casi 2 veces menos la probabilidad de infectarse que las personas que no están vacunadas. Estas diferencias son significativas. Y aunque también sabemos que millones de residentes del condado de Los Ángeles tienen cierta protección contra el COVID porque se infectaron recientemente, esta protección no disminuye las ventajas que ofrecen las vacunas. Hay varias razones convincentes para seguir promoviendo las vacunas. Sabemos que la inmunidad a los coronavirus disminuye con el tiempo, independientemente de si se derivó de una infección o vacunación previa, por lo que es probable que con la circulación continua de variantes fácilmente transmisibles, nuestro sistema inmunológico deba reforzarse. Volver a infectarse sería una estrategia mucho más arriesgada, para mantener un nivel alto de protección que recibir una dosis de refuerzo o una dosis adicional. Los datos emergentes también sugieren que las vacunas brindan una excelente protección a las personas que ya han sido infectadas con COVID. En un estudio reciente del MMWR, el recibir la vacuna contra el COVID protegió contra la hospitalización para las personas previamente infectadas y una dosis de refuerzo brindó el nivel más alto de protección. Y para aquellos que aún no han sido vacunados y que aún no han sido infectados, infectarse puede resultar y resulta en enfermedad grave para muchas personas y para algunas, COVID prolongada causa una enfermedad debilitante. Por el contrario, se ha demostrado que las vacunas son muy seguras y disminuyen de manera confiable el riesgo de enfermedad grave, COVID prolongado, hospitalizaciones y muerte. Y eso se ha mantenido en todas las variantes hasta la fecha. Dada la continua imprevisibilidad del virus y la seguridad y eficacia establecida de las vacunas, nuestra esperanza es de que los residentes y trabajadores aprovechen el amplio suministro y el fácil acceso a vacunas y dosis de refuerzo, permitiéndonos detener ciclos de transmisión y proteger a los más vulnerables de los efectos devastadores de este virus. A pesar de los beneficios conocidos de las vacunas, se ha vacunado a un número relativamente pequeño de niños entre 5 y 11 años de edad. Como puede ver en este gráfico, hicimos un buen progreso en la vacunación de este grupo hasta enero, cuando las tasas comenzaron a estancarse. Y hasta el 24 de abril, solo el 37% de los niños de 5 a 11 años habían recibido una o más dosis de COVID-19. Entendemos que algunos padres pueden dudar en vacunar a sus hijos, mientras que las tasas de COVID son relativamente bajas y los niños han sufrido enfermedades menos graves que los adultos. Es posible que otros padres no estén seguros de que si las vacunas contra el COVID son seguras para los niños pequeños. Y a otros les gustaría que sus hijos fueran vacunados, pero aún no han tenido la oportunidad de recibirlas. Esto es lo que nos gustaría asegurarnos de que los padres sepan. Aunque no es probable que la mayoría de los niños se enfermen gravemente a causa de COVID, algunos se enfermarán gravemente o van a desarrollar una COVID prolongada y los niños pueden transmitir fácilmente el virus a otros a que podrían enfermarse gravemente. A nivel nacional, decenas de miles de niños han sido hospitalizados con COVID-19 y trágicamente más de 900 niños han muerto a causa de COVID desde el comienzo de la pandemia. Y si bien estos números para algunos parecen insignificantes, casi no hay enfermedades infecciosas circulando en los Estados Unidos que causen ese nivel de muerte entre los niños, lo que amplifica la necesidad de hacer todo lo posible para reducir esta tragedia insoportable. Además, cada vez hay más pruebas de que incluso los niños sanos pueden sufrir complicaciones que son graves por COVID-19. En un estudio reciente, del MMWR sobre hospitalizaciones entre niños de 5 a 11 años. 3 de cada 10 niños hospitalizados no tenían ningún problema de salud subyacente. Los datos también han demostrado que los niños que están vacunados corren el mayor riesgo, que los niños que no están vacunados corren el mayor riesgo de enfermarse gravemente. Por ejemplo, en el mismo estudio, 9 de cada 10 niños hospitalizados no estaban vacunados. Y de manera similar a las recomendaciones para los adultos, las vacunas se recomiendan para niños de 5 en adelante, incluso si han tenido COVID. Los niños que fueron infectados pueden tener cierta inmunidad natural, pero no podemos predecir qué tan fuerte o duradera será esa protección. Por lo tanto, las vacunas para niños, al igual que las vacunas para adultos, son la mejor opción y la más segura para desarrollar la inmunidad. Los niños que tuvieron COVID deben esperar hasta que se hayan recuperado de estar enfermos y hayan cumplido con su periodo de aislamiento para vacunarse. Con la llegada del verano y la posibilidad de más variantes infecciosas, es probable que los niños tengan más oportunidades de exponerse al COVID. Vacunar a su hijo o ponerlo al día si le falta alguna dosis puede aumentar su protección y la protección de los niños vulnerables y las personas que los rodean antes de viajar o participar en actividades del verano, incluidos los campamentos de verano, donde pueden mezclarse con personas de muchas otras comunidades. Hay mucha información disponible sobre las vacunas que puede ser difícil de clasificar. Los padres que tengan preguntas sobre vacunas o dosis de refuerzo o que deseen hacer una cita para una vacuna gratuita, pueden hablar con el proveedor de su hijo, visitar vacunatelosangeles.com o llamar a nuestra línea de información sobre COVID al 833-540-0473 de 8 en la mañana a 8 de de 8 en la mañana a 8:30 en la noche, todos los días. Next slide, please. Y finalmente queremos recordarles sobre los requisitos y recomendaciones del uso de mascarillas. Con una alta transmisión en la comunidad y el potencial de más variantes infecciosas en el condado, una de las mejores y más fáciles cosas que podemos hacer para prevenir la infección es usar una mascarilla o respirador de alta filtración que se ajuste bien cuando estemos en el interior de cualquier ubicación con otras personas. Se requieren mascarillas según las normas locales o estatales en entornos seleccionados de alto riesgo, incluso si está completamente vacunado y reforzado. Todo el mundo, el personal, los visitantes, los pacientes y los residentes requieren el uso de mascarillas en entornos de atención médica, así como en entornos de atención a largo plazo e instalaciones de atención para personas mayores, albergues y centros de enfriamiento, instalaciones correccionales y centros de detención. También se requieren mascarillas para todos a partir de los 2 años de edad, independientemente de su estado de vacunación contra el COVID, en todo el transporte público dentro del condado de Los Ángeles y en el interior de los centros de transporte del condado de Los Ángeles. Viajar en medios de transporte públicos aumenta el riesgo de que una persona contraiga y propague el COVID al poner a las personas en contacto cercano con otras, a menudo durante largos periodos de tiempo y muchas veces en sitios que pueden tener ventilación inadecuada. Cuando las personas usan una mascarilla o un respirador que se ajuste bien, se protegen a sí mismos y a quienes les rodean y ayudan a que los viajes y que el transporte público sean más seguros para todos. Se requieren mascarillas en los trenes subterráneos, autobuses, taxis, viajes compartidos en el condado de Los Ángeles. Y también se requiere máscara en los interiores de centros de transporte en nuestro condado, incluidas las terminales de aeropuertos, de autobús, las estaciones de tren y metro, terminales portuarias o cualquier otra área interior que sirva como centro de transporte. Como siempre, las empresas y negocios tienen la discreción de exigir el uso de mascarillas para la protección de sus trabajadores y clientes. Aunque no es obligatorio, se recomienda el uso de mascarillas y respiradores en la mayoría de los lugares públicos cerrados para todas las personas mayores de 2 años. Esto incluye en las empresas, restaurantes, sitios de entretenimiento como salas de cine, en sitios de reunión, en los interiores de sitios de reunión y en entornos educativos como colegios o universidades, escuelas o guarderías. Para su propia protección y la protección de los demás, seguimos pidiendo a todos que consideren usar mascarillas en los interiores de estos entornos, especialmente si tienen un mayor riesgo de enfermarse gravemente o si viven o trabajan o cuidan a alguien que son más vulnerables. Para terminar, desde el comienzo de la pandemia, todos hemos tenido que tomar decisiones sobre cómo protegernos mejor a nosotros mismos y a los demás contra el COVID. Con los casos en aumento, el potencial de las variantes más contagiosas y muchas oportunidades de exposición, este es un buen momento para tomar la decisión de vacunarse o ponerse la vacuna de refuerzo y usar una mascarilla o un respirador cuando esté en el interior con otras personas. Muchas gracias.
Thank you so much, Jackie, and thank you to everyone who attended today. Any additional media questions can be sent to our media inbox at media@ph.lacounty.gov. Thank you once again for joining us, and we'll see you next week.